This discussion is going to be on the cardiovascular system, Chapter 9. Our objectives for today are to recognize the role of the physical therapist assistant in primary, secondary, and tertiary prevention of cardiovascular pathology, recognize the differences in cardiac physiology and pathology, recognize common cardiovascular pathologies and physical signs and symptoms of worsening cardiovascular status, and recognize sternal precautions that may affect types of therapeutic activity included or excluded from post-operative cardiac plan of care. The cardiovascular system functions in coordination with the pulmonary system to circulate oxygenated blood through the arterial system to all cells. The oxygenated blood is then collected from the venous system and delivered to the lungs for reoxygenation. Pathological conditions of the cardiovascular system are varied, multiple, and complex. The heart is a vital organ responsible for pumping blood throughout the body. Here's an overview of its structure and circulation. Deoxygenated blood returns to the heart from the body through the superior and inferior vena cava, entering the right atrium. Blood then passes through the tricuspid valve into the right ventricle. During ventricular systole or contraction, the right ventricle pumps blood through the pulmonic valve into the pulmonary artery. In the lungs, blood exchanges carbon dioxide for oxygen in the pulmonary capillary system. Oxygenated blood returns to the heart via the pulmonary veins entering the left atrium. From the left atrium, blood flows through the mitral valve into the left ventricle. The left ventricle pumps oxygen-rich blood into the systemic circulation through the aorta to supply tissues with oxygen. Oxygen-depleted blood returns to the heart through the superior and inferior vena cava to begin the cycle again. The heart wall consists of three main layers: the epicardium, the outer layer composed of connective tissue and epithelium; myocardium, the middle layer, made up of cardiac muscle tissue responsible for contraction; and endocardium, the inner layer consisting of endothelial cells that line the chambers of the heart and valves. This structure and circulation allows the heart to efficiently pump blood throughout the body, delivering oxygen and nutrients to tissues and removing waste products. Arteries and veins are essential components of the circulatory system responsible for transporting blood throughout the body. Here's an overview of their structure and function. We have elastic arteries, also known as conducting arteries. They are the largest arteries in the body, such as the aorta and its major branches. They are able to stretch and recoil in response to changes in blood pressure, accommodating the surge of blood ejected from the heart during ventricular contraction. We have muscular arteries, which are also known as distributing arteries. They carry blood to specific organs and areas of the body. They're smaller in diameter than elastic arteries, but have a thicker muscular layer in their walls. Regulation of blood flow to specific tissues is achieved through constriction or dilation of the smooth muscle layer in their walls. Arterioles, also known as resistance vessels, they are the smallest arteries and regulate blood flow into capillary networks. Contraction of smooth muscle in their walls adjusts to resistance to blood flow, regulating blood pressure and determining the quality of blood entering specific organs. Venules are small diameter vessels that receive blood from capillaries. Blood exits venules and enters larger venous channels, transitioning into veins. Veins carry blood towards the heart from various parts of the body. They are able to accommodate varying amounts of blood with minimal change in blood pressure due to their high elasticity. Structurally, veins possess one-way valves that prevent backflow of blood and ensures the movement toward the heart. Valves are more abundant in the peripheral veins, aiding in the return of blood against gravity, particularly in the extremities. Overall, arteries and veins play crucial roles in maintaining blood flow, regulating blood pressure, and ensuring efficient circulation throughout the body. Here you can see the muscle pump mechanism. So in veins, one-way valves aid circulation by preventing backflow of venous blood when pressure in a local area is low. In image A, you can see local high blood pressure pushes the flaps of the valves to the side of the vessel, allowing easy flow. In image B, you can see when pressure below the valve drops, blood begins to flow backward but fills the pockets formed by the valve flaps, pushing the flaps together and thus blocking further backflow. Cardiac output is indeed a crucial measure of heart function, representing the volume of blood pumped by the heart in 1 minute. It's determined by two main factors, stroke volume and heart rate. Stroke volume you will see written as SV. Stroke volume refers to the amount of blood ejected by the ventricle with each heartbeat or contraction. It's essentially the volume of blood pumped out of the heart per beat. Factors influencing stroke volume include preload, which is the volume of blood in the ventricle at the end of diastole, contractility, the strength of ventricular contraction, and afterload, which is the pressure the heart must overcome to eject blood. Heart rate, written as HR. Heart rate is the number of times the heart beats per minute. It's influenced by factors such as autonomic nervous system activity, hormonal regulation, and metabolic demands on the body. The equation CO equals SV times HR illustrates how cardiac output is calculated. By multiplying stroke volume, the volume of blood pumped per heartbeat, by heart rate, which is the number of beats per minute, we obtain the total volume of blood pumped by the heart per minute. For example, if the stroke volume is 70 milliliters per minute per beat and the heart rate is 70 beats per minute, the cardiac output would be CO equals 70 mLs per beat times 75 beats per minute, and that equals 5,250 milliliters per minute. This means that the heart is pumping approximately 5,250 milliliters of blood per minute, which is within the typical resting range of cardiac output. Peripheral resistance is a crucial factor in regulating blood flow and maintaining blood pressure within the circulatory system. Here's a breakdown of how it works. Peripheral resistance refers to the resistance encountered by blood flow as it travels through the peripheral or the smaller blood vessels, such as arterioles and capillaries. This resistance is primarily due to the friction between the blood and the vessel walls. Factors influencing peripheral resistance include blood viscosity, which is the thickness or viscosity of blood that affects its ability to flow through the vessels. Higher viscosity increases resistance of flow. Vessel diameter. The smaller the diameter of blood vessels, such as arterioles and capillaries, the greater the resistance of blood flow. This is due to increased friction between the blood and vessel walls. Role in blood pressure regulation. Peripheral resistance in arterioles plays a significant role in determining arterial blood pressure. When arterioles constrict, also known as vasoconstriction, resistance to blood flow increases, causing blood pressure to rise. Conversely, when arterioles dilate, vasodilation, resistance decreases, leading to a drop in blood pressure. Vasomotor mechanism. This is the muscular coat, smooth muscle layer, present in arterioles, allows them to constrict or dilate in response to various stimuli. This regulatory mechanism is known as the vasomotor mechanism. Vasoconstriction reduces the diameter of arterioles, increasing resistance to blood flow and decreasing blood flow into tissues. Vasodilation, on the other hand, relaxes vascular muscles, widening arterioles, reducing resistance, and increasing blood flow to tissues. So here is an analogy. Peripheral resistance can be linked to pinching off the end of a garden hose. Just as pinching the hose increases pressure and flow of water, constriction of arterioles increases blood pressure and flow, while dilation increases pressure and flow. Peripheral resistance and vasomotor mechanisms play critical roles in regulating blood flow, distributing blood to tissues as needed, and maintaining stable blood pressure throughout the body. Peripheral resistance and arterial pressure. Peripheral resistance refers to the resistance to blood flow imposed by the walls of arterioles. It helps determine arterial pressure by controlling the rate of arterial runoff, which is the amount of blood that flows out of the arteries into the arterioles. Greater resistance leads to reduced arterial runoff, resulting in more blood flow, more blood remaining in the arteries, and higher arterial pressure. Local and systemic effects. Peripheral resistance can act locally within a specific tissue or organ, affecting blood flow to that area. It can also have systemic effects affecting blood pressure throughout the entire circulatory system. Total peripheral resistance, also written as TPR. Total peripheral resistance refers to the overall resistance to blood flow offered by the entire systemic vasculature. An increase in total peripheral resistance, often due to widespread arterial constriction, leads to higher arterial pressure. Blood pressure is the force exerted on arterial walls. It is regulated by blood flow and peripheral vascular resistance. Systolic is pressure in the arteries when the heart is contracting, and diastolic is the pressure in the arteries when the heart is relaxed. Blood pressure regulation. Blood pressure is determined by two factors: cardiac output, which is the volume of blood pumped by the heart per minute, and peripheral vascular resistance, which is the resistance to blood flow in the blood vessels. Cardiac output is influenced by stroke volume, the volume of blood ejected from the heart with each beat, and heart rate, the number of heartbeats per minute. Peripheral vascular resistance depends on factors such as the diameter of blood vessels and blood viscosity. Together, cardiac output and peripheral vascular resistance regulate blood pressure by controlling the amount of blood pumped by the heart and the ease with which blood flows through the blood vessels. Nephrosclerosis refers to the condition characterized by hardening of the kidney tissue. In the United States and Europe, terms like hypertensive nephrosclerosis, benign nephrosclerosis, and nephroangiosclerosis are often used interchangeably to describe this clinical condition. It is typically associated with chronic hypertension, which leads to damage and sclerosis of the small arteries and arterioles in the kidneys. Nephrosclerosis can ultimately result in impaired kidney function and may contribute to conditions like chronic kidney disease and renal failure. Blood pressure pathologies can either be related to blood flow, such as volume and cardiac output, or peripheral resistance, such as diameter or viscosity. Hypertension or high blood pressure is a prevalent medical condition characterized by elevated blood pressure levels. More than 60 million cases of hypertension have been diagnosed in the United States alone. It is defined as blood pressure exceeding 140/90 millimeters of mercury. Primary or essential hypertension accounts for around 90% of cases and often has no identifiable cause, which means that it is idiopathic. Secondary hypertension, on the other hand, results from underlying medical conditions or external factors that contribute to elevated blood pressure levels. Causes of secondary hypertension: medications. Certain medications such as corticosteroids, non-steroidal anti-inflammatory drugs, NSAIDs, decongestants, and oral contraceptives can contribute to secondary hypertension. Alcohol or ETOH. Excessive alcohol consumption can lead to hypertension. Renal failure. Kidney disease or renal failure can impair the regulation of blood pressure, leading to hypertension. Pregnancy. Hypertension can develop during pregnancy, a condition known as gestational hypertension or preeclampsia. Endocrine disease. Hormonal disorders such as hyperthyroidism or Cushing syndrome can cause secondary hypertension. Acute stress. Stressful situations or acute stress responses can temporarily elevate blood pressure levels. Collagen disease. Certain collagen vascular diseases such as systemic lupus erythematosus or scleroderma may contribute to hypertension. Increased intracranial pressure. Conditions that elevate intracranial pressure, such as brain tumors or intracranial hemorrhage, can lead to secondary hypertension. Metabolic syndrome refers to the clustering of multiple cardiovascular risk factors that increase the likelihood of developing cardiovascular disease, CVD, or type 2 diabetes. Risk factors associated with metabolic syndrome include abdominal obesity, insulin resistance or glucose intolerance, high blood pressure, and dyslipidemia, which is abnormal lipid levels. Individuals with metabolic syndrome are at higher risk for developing conditions such as heart disease, stroke, and type 2 diabetes. Pulmonary insult refers to any injury or damage affecting the lungs or the pulmonary system. This can include conditions such as acute respiratory distress syndrome, ARDS, pneumonia, pulmonary embolism, or chronic obstructive pulmonary disease, also known as COPD. Pulmonary insult can impair lung function and gas exchange, leading to respiratory compromise and potentially life-threatening complications. Kidney insufficiency or impaired renal function refers to decrease in kidneys' ability to filter and excrete waste products and regulate fluid and electrolyte balance effectively. Conditions such as chronic kidney disease, CKD, acute kidney injury, AKI, or renal insufficiency can result in kidney insufficiency. Impaired kidney function can lead to electrolyte imbalances, fluid retention, hypertension, and accumulation of waste products in the body. Prothrombotic state, hypercoagulability state. A prothrombotic state, also known as hypercoagulability state, refers to a condition characterized by an increased tendency towards blood clotting or coagulation within the bloodstream. This hypercoagulability state can predispose individuals to thrombotic events such as a deep vein thrombosis, DVT, pulmonary embolism, PE, or stroke. Various factors, including genetic predisposition, acquired conditions, and certain medications or medical conditions, can contribute to the development of prothrombotic state. Encephalitis is an acute inflammation of the brain, typically caused by viral infections or autoimmune reactions. Symptoms of encephalitis can include fever, headache, altered mental status, seizures, and neurological deficits. Severe cases of encephalitis can lead to significant brain damage, coma, or death if not promptly diagnosed and treated. Primary hypertension, also known as essential hypertension, refers to high blood pressure without a specific cause. While the exact cause of primary hypertension is not fully understood, it is believed to result from a combination of genetic predisposition and lifestyle factors. Risk factors associated with primary hypertension include obesity, sedentary lifestyle, unhealthy diet, high sodium intake, alcohol consumption, smoking, stress, and family history of hypertension. In the early stages, hypertension often presents without noticeable symptoms, earning it the label the silent killer. However, as the condition progresses, individuals may begin to experience various symptoms and complications. Late-stage hypertension can lead to headaches. Persistent or severe headaches may occur due to an increased pressure within the blood vessels in the brain. Vertigo or dizziness or a sensation of spinning may result from compromised blood flow to the brain. Flushed face. Facial flushing or redness may occur due to increased blood flow or blood vessel dilation. Spontaneous nosebleeds. Fragile blood vessels in the nose may rupture more easily due to elevated blood pressure. Blurred vision. Vision disturbances may arise due to changes in blood flow to the eyes or damage to the blood vessels in the retina. Nocturnal urinary frequency. Increased need to urinate at night may be a sign of kidney dysfunction or fluid retention associated with uncontrolled hypertension. Morning headache. Headaches upon wakening, particularly in the morning, may indicate elevated blood pressure during sleep. Excessive morning blood pressure. Elevated blood pressure readings in the morning, especially in the older adults with known hypertension, can increase the risk of stroke and other cardiovascular events. It serves as a warning sign that warrants attention and management. These symptoms and signs highlight the importance of regular blood pressure monitoring, especially in individuals at risk for hypertension. Early detection and effective management can help prevent complications and improve long-term outcomes. Hypertension management. This includes lifestyle changes such as aerobic exercise, smoking cessation, reduced sodium diet, low-fat diet, weight loss, and stress reduction techniques. There's also drug therapy, which includes diuretics, which increase water and sodium excretion in the kidneys. ACE inhibitors, which reduce angiotensin II synthesis, which is the hormone responsible for maintaining blood pressure, activated when there is low flow to the kidneys. Alpha blockers reduce the sympathetic tone of blood vessels, which leads to vasodilation and decreased peripheral resistance. Beta blockers reduce the heart rate and contractility, which decrease cardiac output and decrease blood pressure. PTA implications for hypertension. Check vital signs prior, during, and post exercise. Check for a sudden change or increase in blood pressure with any exercise. Monitor people taking NSAIDs and antihypertensive medications. Gradual aerobic exercise program. Heavy isometric and weightlifting could be potentially harmful. Training intensity does not need to be high. Low intensity between 50 and 60% of heart rate max, 3 times per week. Some of the signs and symptoms of cardiovascular disease include chest, shoulder, neck, jaw, or arm pain, palpitations, syncope, fatigue, diaphoresis, dyspnea, nausea, vomiting, cyanosis, and claudication. Claudication refers to leg edema and pain. Cardiovascular disease, especially coronary atherosclerosis, is the most common cause of hospitalization and death in the older population in the United States. Disease-independent changes in the aging heart associated with a reduction in function include a reduction in the number of myocytes and cells within the conduction tissue, the development of cardiac fibrosis, a reduction in calcium transport across membranes, lower capillary density, impaired autonomic reflex control of heart rate, and epicardial fat deposition and brown atrophy caused by intracellular lipofuscin deposits appear to be signs of aging process, but without any obvious effects on function. The heart of older persons, even fit, healthy, and active adults, pump less blood to the skin and require the heart of the older person to work much harder under the same circumstances than that of a younger person. Heart valves review. The heart valves allow blood to flow from one chamber to another. They allow blood to flow out of the heart in one direction and controls the flow of blood through the heart by opening and closing during the contraction of the heart. Mitral and tricuspid valve from the atria to ventricles, and the aortic valve and pulmonary valve out of the ventricles. Valvular defects. Heart problems secondary to valve impairment can result from various causes, including infections like endocarditis, congenital deformities, or acquired diseases. Valve deformities are classified as functional or anatomic, with stenosis and insufficiency being common manifestations. Stenosis refers to narrowing or constriction of the heart valve, preventing it from opening fully. Causes include scars or abnormal deposits on valve leaflets. Stenotic valves obstruct blood flow, leading to increased workload on the chamber behind the affected valve. Surgical replacement may be necessary to alleviate symptoms and restore proper blood flow. Aortic and pulmonary valves are commonly affected by stenosis. Insufficiency, also known as regurgitation. Insufficiency occurs when the heart valve fails to close properly, allowing the blood to flow back into the heart chamber during contraction. This backflow increases the volume of work on the heart, gradually leading to chamber dilation. Prolapse, particularly affecting the mitral and tricuspid valves, involve enlarged leaflets bulging backwards into the atrium. Valve conditions can initially be asymptomatic, but eventually lead to cardiac muscle dysfunction and other complications. Treatment strategies may involve surgical intervention, especially in cases of severe stenosis requiring valve replacement. Among the heart valves, the aortic and pulmonary valves are the most commonly affected by stenosis. Mitral stenosis, the etiology often caused by rheumatic heart disease, more prevalent in women. Clinical features, there's mild, which is asymptomatic with normal left atrial pressure and cardiac output. Moderate dyspnea and fatigue due to rising left atrial pressure and reduced cardiac output. In severe, there's a high left atrial pressure that leads to pulmonary venous congestion, dyspnea, fatigue, and right ventricular failure. Orthopnea and paroxysmal nocturnal dyspnea may occur due to increased pulmonary blood volume when lying down at night. Mitral regurgitation, etiology, various causes with ischemic heart disease being common, associated with female gender, lower BMI, and older age. Clinical features, an acute, abrupt rise in left atrial pressure, possibly leading to pulmonary edema, and chronic progressive left atrial enlargement with exertional dyspnea, fatigue, and possible development of atrial fibrillation may lead to left ventricular failure. Mitral valve prolapse occurs in about 2 to 6% of adults, more common in young women. It's characterized by a slight structural variation in the mitral valve. Leaflets may billow back into the left atrium during ventricular contraction. Clinical features, this may be asymptomatic or present with exertional dyspnea, exercise-induced fatigue, and complications such as atrial fibrillation. Marfan syndrome is a genetic disorder affecting connective tissue strength. Weakness in connective tissue affecting structures like the mitral valve. Mitral valve regurgitation can lead to increased pressure in the pulmonary bed, causing pulmonary hypertension. Symptoms may include paroxysmal nocturnal dyspnea. Ischemic heart disease, also known as coronary artery disease. You will also hear ischemic heart disease, coronary heart disease, or coronary artery disease. This involves narrowing or blockage of coronary arteries, which leads to insufficient oxygen supply to areas of the myocardium, causing ischemia and potential infarction. Symptoms may include angina, which is chest pain or discomfort, shortness of breath, and fatigue. Severe cases can lead to myocardial infarction, which is a heart attack, or sudden cardiac death. Arterial sclerosis types are atherosclerosis, which is the most common form, involves plaques of fatty deposits in the inner layer of the arteries, including coronary arteries. Monckeberg's arterial sclerosis involves the middle layers of the arteries and destruction of muscle and elastic fibers and formation of calcium deposits. Arterial sclerosis is the thickening of small arteries or arterial walls. All three forms may be present in the same individual, affecting different blood vessels. Clinical implications. Arterial sclerosis, particularly atherosclerosis, is the major contributor of coronary artery disease and other cardiovascular diseases. Management focuses on lifestyle modifications such as diet and exercise, medications, including statins or antiplatelets, and interventions such as angioplasty, bypass surgery to prevent or alleviate arterial narrowing and reduce cardiovascular risk. Cardiovascular disease, CVD. Risk factors include demographics. Black and American Mexican women, as well as Black men, are at greater risk for cardiovascular disease. Other risk factors include age, family history, smoking, high blood pressure, high cholesterol, diabetes, obesity, unhealthy diet, physical inactivity, excessive alcohol consumption, and stress. Types of vascular diseases: coronary artery disease, which affects arteries supplying the heart, leading to conditions such as angina and heart attack. Cerebrovascular disease affects arteries supplying the brain, leading to conditions such as stroke and transient ischemic attacks, also known as TIAs. Peripheral vascular disease, PVD, affects arteries outside the heart and brain, typically in the legs, leading to reduced blood flow, claudication, which is pain with walking, and potential complications such as ulcers and gangrene. Aneurysm, which is abnormal bulging or ballooning of a blood vessel, which can occur in various locations in the body and may rupture if left untreated. Intestinal infarction, reduced blood supply to the intestines, often due to atherosclerosis or blood clots, leading to tissue damage and potentially life-threatening complications. This is an updated model of atherosclerosis. Endothelial injury. Atherosclerosis begins with an injury to the endothelial lining of the artery, allowing circulating lipoproteins to penetrate into the intimal layer, which is that inner layer. Penetration of lipoproteins into the smooth muscle cells of the intima leads to the formation of fatty streaks, initiating the development of a coronary lesion. The coronary lesion initially grows outward in a compensatory manner known as positive remodeling to maintain an open lumen. This involves the formation of a fibrous cap to separate the plaque from the arterial lumen. Gradually, the plaque builds up, pressing inward into the lumen, obstructing blood flow and potentially leading to rupture or thrombus formation. A blood clot known as an intraplaque thrombus may form within the plaque, contributing to its stability or instability. Plaques with a thin fibrous cap and packed with viscous cholesterol and white blood cells are more likely to rupture. Rupture of this plaque and subsequent thrombus formation can lead to myocardial infarction or stroke. Vascular disease, including atherosclerosis, is considered a disease of the arterial wall. This concept emphasizes that the pathology occurs within the vessel wall itself rather than just within the lumen. This updated model highlights the dynamic nature of atherosclerosis and the importance of understanding plaque composition, stability, and rupture mechanism in the development of cardiovascular events. Symptoms of coronary artery disease can include angina pectoris, which is chest pain, myocardial infarction, MI, and even death. Angina pectoris refers to chest pain or discomfort caused by reduced blood flow to the heart muscle, typically due to coronary artery narrowing or blockage. Myocardial infarction, or MI, commonly known as a heart attack, occurs when the blood flow to part of the heart is blocked for an extended period of time, leading to tissue damage or cell death. Non-modifiable risk factors for coronary artery disease include age. Advanced age is a significant risk factor for coronary artery disease, with the incidence increasing with age. Gender, men generally have a higher prevalence of heart disease compared to women, although women may experience heart attacks later in life, possibly due to hormonal factors. A family history of coronary artery disease or premature heart disease increases the risk for developing coronary artery disease. Certain ethnicities, such as African American, Hispanic, and South Asian populations, have a higher prevalence. Bacterial or viral infections, especially chronic infections, may contribute to the development of coronary artery disease. Modifiable risk factors for coronary artery disease include hypertension, dyslipidemia, diabetes mellitus, smoking, obesity, physical inactivity, unhealthy diet, stress, and excessive alcohol consumption. These risk factors can be addressed through lifestyle modification and medical interventions to reduce the risk of coronary artery disease and its complications. Radioisotope studies are used to determine the degree of perfusion to the myocardium. These studies involve the injection of a radioactive tracer, which allows visualization of the blood flow through the heart muscle. By assessing perfusion patterns, areas of reduced blood flow can be identified, indicating potential areas for ischemia or infarction. The test described is a stress test, also known as an exercise stress test or cardiac stress test. It is indeed used in medicine and cardiology to assess the heart's response to external stress, typically induced by exercise in a controlled clinical environment. Cardiovascular disease treatment includes pharmacology to decrease oxygen demand and increase blood flow to the heart. There are a number of different medications used, including nitrates, beta blockers, calcium channel blockers, diuretics, aspirin. There's also surgical interventions, percutaneous transluminal coronary angioplasty, PTCA, coronary stents, coronary artery bypass graft or CABG, transplantation or ventricular assistive device. Also, a diet with low sodium, cholesterol, and weight reduction. Percutaneous transluminal coronary angioplasty can open an occluded coronary artery without opening the chest, which is an important advantage over bypass surgery. Once coronary angiography has been performed to determine the presence and location of an arterial occlusion, a guide catheter is threaded through the femoral artery into the left coronary artery. When the angiography shows the guide catheter positioned at the site of the occlusion, the uninflated balloon is centered in the obstruction. A smaller double lumen balloon catheter is inserted through the guide catheter. The balloon is inflated, compressing the plaque against the arterial wall, and deflated until the angiogram confirms a reduced pressure gradient in the vessel. The balloon is removed and the artery is left unoccluded. Application of a coronary stent. Here you can see in image A, a severely occluded coronary artery. B and C shows a blocked coronary artery can be held open using a balloon expanded device called a coronary stent. And in image D, you can see the stent maintains an open vessel, allowing blood to pass through freely. Biodegradable stents are under development and reduce or eliminate problems associated with metal stents. Delivery of drugs or gene therapy to initiate intimal hyperplasia and prevent post-angioplasty restenosis is under investigation.
Coronary angioplasty, also called as the percutaneous transluminal or balloon angioplasty, is a treatment procedure to restore the blood flow in the narrowed or blocked coronary arteries caused due to plaques or blood clots. Most coronary angioplasty procedures last between 30 minutes to 3 hours. Once the patient is admitted, his heart is monitored and is given an intravenous sedative to relax the body. A needle is inserted through the wrist into the radial artery. A guard wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope. At this point, the guard wire is removed and the tip of catheter is positioned to enter the coronary artery. A special dye is injected which allows the fluoroscope to take X-ray images of the arterial interiors and help in identifying the position of the block. This is called angiogram. Once the blockage is identified, a flexible guard wire is inserted into the artery vessel, followed by a balloon-tipped catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is applied over the radial artery to prevent bleeding. One will need to lie down for several hours, during which signs of bleeding or chest pain will be monitored. The patient may either be discharged on the same day or after an overnight stay at the hospital.
Coronary artery bypass graft, also known as CABG, is a surgical procedure used to treat coronary artery disease by improving blood flow to the heart muscle. Here are some key points about CABG. During CABG, a surgeon takes a healthy blood vessel, usually a section of the saphenous vein from the leg or the internal mammary artery from the chest, and grafts it onto the coronary artery beyond the blockage. This creates a new pathway for blood flow to bypass the blocked or narrowed portion of the coronary artery, allowing oxygen-rich blood to reach the heart muscle. CABG is typically recommended for individuals with severe coronary artery disease who have multiple blockages in their coronary arteries and/or have already experienced heart muscle damage. It may also be recommended for those who have not responded well to other treatments such as medication or angioplasty. Traditional CABG involves a sternotomy where the chest is opened through the breastbone, allowing access to the heart. However, newer techniques such as off-pump CABG or minimally invasive CABG have involved smaller incisions and avoid the need for full sternotomy. Off-pump CABG is performed without the use of a heart-lung bypass machine, while minimally invasive CABG involves smaller incision and specialized instrument. CABG is highly effective in relieving symptoms of coronary artery disease, such as chest pain, and improving blood flow to the heart muscle. It can also reduce the risk of heart attack and improve overall quality of life for patients with severe coronary artery disease. Recovery from CABG typically involves a hospital stay of several days to a week, followed by a period of rehabilitation and recovery at home. Most patients are able to return to normal activities within a few weeks to months after surgery, although individual recovery times may vary. Overall, CABG remains an important and effective treatment option for individuals with severe coronary artery disease who are not adequately managed with medications or other interventions.
Coronary artery bypass surgery is, as the name suggests, when you get a blockage in your coronary vessel. To treat that, you have two possible ways. One is to put a stent and push that narrowing or stenosis open. Another option is to actually bypass it. And in coronary artery bypass surgery, what we do is we bypass that blockage. We leave that blockage in place, but we go beyond that blockage and feed that vessel with a new inlet for a fresh blood supply.
There are three major blood vessels that supply blood to the heart. The left coronary artery, which divides into two major branches, and then the right coronary artery. And patients can develop blockages in those arteries that lead to heart disease. Coronary bypass surgery is utilizing either a vein or an artery to bypass the blockages. And the bypasses are usually placed in a location that is far beyond the blockage, thereby not only treating the blockage that's occurring at present, but also treating future blockages for most patients.
You do as many bypasses as necessary to achieve what's called a complete revascularization, meaning that you have bypassed every single significant or sizable vessel to all major territories of the heart.
Cleveland Clinic, for the most part, invented coronary bypass surgery back in the 1960s. Mason Soames was a cardiologist who happened upon coronary angiography, developed really the first coronary angiogram. And together with his surgical colleague, Rene Favellaro, they worked and were able to do the first coronary bypass. And coronary bypass surgery had a tremendous history here at the Cleveland Clinic from the early 1970s. We did far more coronary bypass surgeries here than anywhere else in the world. Coronary artery bypass surgery is certainly the most common operation that heart surgeons perform, and it's actually the most common operation among heart surgery programs in the country. But that doesn't mean that it's the same operation for every patient. Every patient needs a tailored approach to coronary revascularization. So there are multiple approaches for coronary artery bypass surgery. The standard approach is utilizing a full sternotomy, which is a full splitting of the sternum. The surgery can be performed either utilizing the heart-lung machine or what's called off-pump technique, and thereby we use stabilizers to stabilize portions of the heart to do the bypasses we need to do. We can also perform minimally invasive coronary bypass surgery. A lot of those can be performed through a very small incision between the ribs.
We never want to compromise quality for cosmetics because our objective is not to have a perfect immediate outcome. Our objective is to have long-term success.
When we look at performing bypass surgery, we use either the mammary artery, a radial artery from the arm, or a portion of the saphenous vein from the leg. Now, each of these bypasses lasts a certain length of time. They don't last forever. The mammary artery by far lasts the longest. It's one of the only arteries in the body that really does not develop atherosclerosis. So multi-arterial grafting is by far the best strategy for performing coronary artery bypasses for patients because it gives the most long-lasting effect.
Not only do we have a high volume cardiac surgery practice, but the patients we get here are very high-risk patients. We accept patients from all over the country, in fact from all over the world. Many of them have seen one, two, or more surgeons that have declined to offer those patients surgery because of their high risk. And the surgeons here are very comfortable dealing with those patients.
Cleveland Clinic has long been a leader in preoperative coronary artery bypass bypass surgery, that is, new coronary bypasses in someone who's had bypass surgery before. We do the largest number of those cases yearly than any other center.
What we do to achieve excellent results is having a great team approach. We have excellent surgeons, we have excellent support, and we use grafts and techniques that ensure that the patient will have not only excellent short-term outcomes and very low complication rate, but also excellent long-term results.
I think a lot of patients before heart surgery don't actually fully understand how poorly they feel. And what's rewarding is seeing them return to what they were, seeing them really be able to enjoy life again.
CABG exercise management. Knowing the indications as to when to terminate or modify exercises is important. The patient will have sternal precautions after surgery. Progressive activity to increase activity tolerance is ideal. Focus on lower extremity derived aerobic exercises and upper extremity range of motion. Lower extremity exercises have demonstrated to regulate heart rate, lower diastolic blood pressure, and improve oxygen transport. And monitor vital signs closely and use the rate of perceived exertion scale. Here is the rate of perceived exertion. The target would be between 11 and 14. Indications for discontinuing or modifying exercise would include new onset or easily provoked anginal chest pain, increasing frequency, intensity, or duration of angina, which would be unstable angina, discomfort in the upper body, including chest, arm, neck, or jaw, chest pain unrelated to chest incision, fainting, lightheadedness, or dizziness, sudden or severe dyspnea, severe fatigue or muscle pain, nausea or vomiting, back pain during exercise, bone or joint pain or discomfort during or after exercise, and severe leg claudication. Some other clinical signs are pallor, peripheral cyanosis, cold or moist skin, staggering gait or ataxia, confusion or blank stare in response to inquiries, resting heart rate more than 130 beats per minute or less than 40, more than 6 arrhythmias or irregular heartbeats or palpitations per hour, frequent premature ventricular contractions, uncontrolled diabetes, oxygen saturation less than 90%, acute infection or a temperature more than 100 degrees Fahrenheit, persistent drainage or change in drainage from the incision, increased swelling, tenderness, or redness around the incision, inability to converse during activity, blood pressure abnormalities, fall in systolic blood pressure with increase in workload, specifically a decrease of 10 millimeters of mercury or more below any previously recorded blood pressure accompanied by other signs and symptoms, a rise in systolic blood pressure more than 250 millimeters of mercury or diastolic blood pressure above 115 millimeters of mercury, signs of central nervous system involvement, or person indicates need or desire to stop, or a recent myocardial infarction. Some other sternal precautions include a significant ECG change, no driving for 4 weeks post-op, and no pulling up in bed during acute care is allowed. Handheld assist during mobilization may be required instead of an assistive device. No pushing, pulling, or lifting more than 5 to 10 pounds. Avoid shoulder horizontal abduction with extreme external rotation. Sternal splinting for pain, especially during coughing. Progression is based on client tolerance and signs and symptoms of wound healing. And once the incision is fully healed, scar mobilization is permissible. The usual precautions for scar mobilization apply, including mobilizing the tissue in the direction of the scar before using any cross-transverse techniques or mobilizing toward the scar rather than away from the scar to avoid overstretching the healing tissue. Angina pectoris is chest pain or discomfort that occurs when the heart muscle does not receive enough oxygen-rich blood. Here are some key points about angina. Angina is typically caused by coronary artery disease, where the arteries that supply the blood to the heart become narrowed or blocked by atherosclerotic plaque. This leads to reduced blood flow to the heart muscle, especially during times of increased activity or stress when the heart requires more oxygen. The classic symptom of angina is chest pain or discomfort, often described as pressure, squeezing, heaviness, or tightness in the chest. The pain may radiate to the left shoulder, arm, neck, jaw, or back. However, not everyone experiences chest pain with angina. Other symptoms may include unusual fatigue, shortness of breath, weakness, indigestion, nausea, or sweating. There are different types of angina, including stable angina, unstable angina, variant angina, and microvascular angina. Stable angina occurs predictably with exertion or stress and resolves with rest or nitroglycerin. Unstable angina is more serious and can occur at rest or with minimal exertion, often indicating an impending heart attack. The goal of treatment for angina is to relieve symptoms, improve quality of life, and reduce the risk of complications such as heart attack. Lifestyle modifications, medications such as nitroglycerin, beta blockers, calcium channel blockers, and aspirin, and interventions such as angioplasty or coronary artery bypass graft may be recommended depending on the severity and type of angina. PTA implications, rest in a seated or upright position, sublingual nitroglycerin, monitor pulse and respiration, monitor for signs of orthostatic hypotension, administer oxygen as ordered, call EMS if symptoms persist for more than a few minutes. Myocardial infarction is ischemia with resultant necrosis of myocardial tissue. Most common site is left ventricle from left coronary artery. MIs occur more frequently in the early morning hours and during the winter holiday season. Majority of MIs result from coronary thrombus at the site of atherosclerotic stenosis. Risk factors include smoking, hypertension, hyperlipidemia, diabetes, obesity, sedentary lifestyle, and family history of heart disease. Occlusion of the coronary artery by clot deprives myocardium of oxygen, leading to ischemia and necrosis. Typically occurs due to rupture of atherosclerotic plaque. Common symptoms include chest pain or discomfort, pressure, squeezing, tightness, shortness of breath, nausea, vomiting, sweating, and pain in the arms, back, neck, jaw, or stomach. Immediate medical attention is required, involves restoring blood flow, reducing myocardial oxygen demand with the use of beta blockers, and preventing complications. Complications can include arrhythmias, heart failure, cardiogenic shock, and death. Prompt diagnosis and treatment is essential for minimizing damage and improving outcomes. Here's a diagram of electrocardiographic alterations associated with the 3 zones of myocardial infarction. Clinical manifestations include sudden sensation of pressure, crushing chest, pain with radiation to arms, throat, and neck. Nausea, vomiting, and diaphoresis are common. Women may experience different symptoms, including shortness of breath in the middle of the night, chronic unexplained fatigue, pain in mid-thoracic spine, anxiety, and heartburn not relieved with antacids. 80% survive when transported to a coronary care unit. Prognosis depends on the size, location, and amount of damage caused by the myocardial infarction. Emergency treatment includes ventricular defibrillation, CPR only in the case of asystole, rest, thrombolytic agents. Complications can include systemic organ failure, the kidneys are most affected, and cerebral ischemia leading to mental injury and central nervous system dysfunction. Some other post-infarction complications include arrhythmias, congestive heart failure, cardiogenic shock, pericarditis, rupture of the heart, thromboembolism, recurrent infarction, and sudden death. Long-term medical treatment includes coronary artery bypass graft or CABG, anticoagulant therapy, and cardiac rehab programs that include exercise, dietary, and lifestyle modifications. Here's a list of contraindications to exercise post-MI. Cardiac rehabilitation is important for any patient treated for cardiac disease. It includes education and exercise. It begins early after surgical intervention and is individualized prescriptive exercise. It uses the metabolic equivalents or METs as guidelines for prescription of exercise. Monitoring vital signs and rate of perceived exertion. Limits on heart rate after surgery will be directed by the physician, and monitoring vital signs during exercise, including SpO2, heart rate, respiratory rate, blood pressure, and signs and symptoms pre, during, and post-exercise. Indications for discontinuing or modifying exercises: new onset of easily provoked anginal chest pain, increasing frequency and intensity or duration of angina, discomfort in the upper body including chest, arm, neck, or jaw, fainting, lightheadedness, or dizziness, sudden or severe dyspnea, severe fatigue or muscle pain, nausea and vomiting, back pain during exercise, bone or joint pain or discomfort during or after exercise, and severe leg claudication. Pallor, staggering gait, confusion or blank stare in response to inquiries, resting heart rate more than 130 beats per minute or less than 40 beats per minute, irregular heartbeats, frequent PVCs, uncontrolled diabetes, and oxygen saturation of less than 90%. Other signs include acute infection or a temperature of more than 100.4, persistent drainage or change from any incision, increased swelling, tenderness, or redness around the incision site, inability to converse during activity, and changes in blood pressure as noted. Congestive heart failure, or CHF, is a condition where the heart is unable to pump sufficient blood to meet the body's needs. Structural changes include loss of myofilaments, apoptosis, disturbances in calcium homeostasis, alteration in receptor density, signal transduction, and collagen synthesis. These changes result from a cardiac event like a myocardial infarction and lead to impaired cardiac function and circulatory congestion. Backup of blood into the pulmonary veins and high pressure in the pulmonary capillaries lead to pulmonary congestion and hypertension. Failure may affect both sides of the heart or predominantly one side, left or right. Left ventricular failure is referred to as congestive heart failure. Acute right ventricular failure, almost exclusively seen in massive pulmonary embolism, is termed cor pulmonale. Cor pulmonale is heart disease arising from underlying pulmonary pathology. Result of left ventricular failure: inability of the left ventricle to adequately pump blood to meet the body's metabolic demands. Etiology is hypertension. Prolonged high blood pressure can lead to left ventricular hypertrophy and impaired contractility. And ischemia, which is reduced blood flow to the heart muscle, often due to coronary artery disease, can result in myocardial damage and impaired left ventricular function. Some of the clinical manifestations include dyspnea, which is shortness of breath, especially with exertion or lying down. Paroxysmal nocturnal dyspnea, which is a sudden onset of shortness of breath during sleep, often leading to the need to sit or stand up to breathe comfortably. Orthopnea, difficulty breathing when lying flat, which is relieved by sitting up or standing due to redistribution of fluid from the lower extremities to the lungs in supine position. Fatigue and muscle weakness, increased heart rate or tachycardia, decreased peripheral blood flow, and renal changes. Result of right ventricular failure: inability of the right ventricle to effectively pump blood to the lungs, leading to pulmonary congestion and peripheral edema. Etiology: left-sided congestive heart failure. Elevated left-sided pressures can lead to increased pulmonary venous congestion, eventually causing right ventricular failure. Clinical manifestations include dependent edema, which is swelling in the lower extremities due to fluid retention, typically worsening throughout the day and improving overnight when the patient is in a recumbent position. Jugular venous distension, visible distension of the jugular veins in the neck due to increased central venous pressure, reflecting right-sided heart dysfunction. Right upper quadrant and abdominal pain. Hepatic congestion can lead to discomfort or pain in the right upper quadrant of the abdomen, often accompanied by hepatomegaly. Cyanosis of the nail beds, bluish discoloration of the nail beds due to poor oxygenation of blood, indicating hypoxemia resulting from inadequate pulmonary circulation. Here you can see the differences of signs and symptoms from left ventricle failure and right ventricle failure. These are important to know. Medical management is to treat the underlying problems. Non-pharmacological interventions include sodium restriction, exercise, and lifestyle modification. Pharmacological interventions include diuretics, beta blockers, and ACE inhibitors, and surgery, which is indicated to treat the underlying cause, including a CABG, heart transplant, and pacemaker placement. Implications for the PTA. Positioning plays a crucial role in managing patients with CHF. To alleviate symptoms and prevent complications, here are some key points regarding positioning. High Fowler's position, which is elevating the head of the bed to at least 20 inches above the level, helps reduce pulmonary congestion by facilitating diaphragmatic expansion and improving ventilation. This position can also alleviate dyspnea by reducing pressure on the diaphragm. Dependent position of legs. Keeping the legs in a dependent position helps decrease venous return to the heart, thereby reducing preload and preventing further fluid accumulation. This position assists in minimizing peripheral edema and venous congestion. Avoid elevating feet. Elevating the patient's feet should be avoided because it can increase venous return to the heart, leading to increased preload and exacerbating heart failure symptoms. Instead, maintaining the legs in a dependent position is preferred to promote venous return. Range of motion exercises. Encouraging the patient to perform range of motion exercises helps decrease venous pooling in the extremities and promote circulation. These exercises can prevent venous stasis and reduce the risk of thrombophlebitis. Monitoring for complications. It is essential to monitor patients for signs of complications such as thrombophlebitis, indicated by unilateral swelling, calf pain, and pallor. Early detection of these signs allows for prompt intervention and prevent further complications. Overall, proper positioning techniques are integral components of CHF management to optimize respiratory function, alleviate symptoms, and reduce the risk of complications. Trendelenburg can compromise ventilation, venous return, increase preload, and increase myocardial wall stress. Arrhythmias are disturbances of heart rate or rhythm caused by abnormal rate of electrical impulse. Arrhythmias, also known as dysrhythmias, refers to disturbances in the rate or rhythm of the heart. The heart's rhythm is controlled by the sinoatrial node, or SA node, which acts as the heart's natural pacemaker. The SA node generates electrical impulses that travel through the cardiac conduction system, stimulating the atria and ventricles to contract and pump blood effectively. Arrhythmias can manifest as abnormalities in heart rate, too fast or too slow, or rhythm, irregular. They can occur in the atria, supraventricular, or ventricles. Arrhythmias can be caused by various factors, including abnormalities in the SA node electrical impulses, abnormal conduction pathways in the heart, or underlying heart conditions such as coronary artery disease, heart failure, or structural heart defects. Other factors like electrolyte imbalances, medication side effects, and stimulants, example caffeine or nicotine, can also contribute to arrhythmias. The symptoms of arrhythmias can vary widely and may include palpitations, chest pain, dizziness, lightheadedness, fainting, also known as syncope, shortness of breath, fatigue, and anxiety. In some cases, arrhythmias may be asymptomatic and detected incidentally during medical evaluation. Arrhythmias are diagnosed through various methods, including electrocardiogram, or ECG or EKG, a Holter monitoring, event monitoring, stress testing, echocardiogram, and electrophysiologic studies. The management of arrhythmias depend on the underlying cause, severity of symptoms, and associated complications. Treatment options may include medications, antiarrhythmics, electric cardioconversion, catheter ablation, implantation devices such as pacemakers, and lifestyle modifications. Arrhythmias are common cardiac disorders that require comprehensive evaluation and individualized management to optimize patient outcomes and prevent complications. Here's a breakdown of some of the common cardiac rhythm abnormalities and their treatments. Atrial fibrillation is characterized by rapid, irregular contractions of the atrial myocardium. Symptoms may include palpitations, chest pain, dyspnea, and dizziness. Treatment aims to control ventricular rate, prevent thromboembolism, and restore normal sinus rhythm. Cardioversion may be used to restore normal rhythm. Anticoagulant therapy is often prescribed to reduce the risk of stroke. Ventricular fibrillation results in uncoordinated contractions of the ventricular muscle and can lead to cardiac arrest. Treatment involves defibrillation and depolarize the muscle and restore normal rhythm. Immediate intervention is crucial for survival. Heart block is caused by interruptions to the passage of impulses through the heart's electrical system. It can result from misfiring of the SA node or conduction abnormalities. Treatment may involve pacemaker placement to regulate heart rate and ensure proper conduction. Sick sinus syndrome, a complex arrhythmia and conduction disturbance associated with advanced age, coronary artery disease, and drug therapy. Treatment focuses on controlling symptoms, regulating heart rate, and restoring normal sinus rhythm if possible. Pacemaker placement may be necessary in some cases to maintain adequate heart rate and rhythm. Overall, the treatment of cardiac rhythm abnormalities involves a combination of pharmacological interventions, electrical, cardioversion, and in some cases, surgical procedures like pacemaker placement. The goal is to manage symptoms, prevent complications, and improve overall cardiac function and quality of life. Classifications of arrhythmias. A bradycardia is a heart rate less than 50 beats per minute. Tachycardia is heart rate over 100 beats per minute. Atrial fibrillation is irregular rhythm that's caused by the atria that causes the atria to quiver and preventing effective blood transport to the ventricles. Ventricular fibrillation is the most dangerous because the heart cannot pump blood. It causes the ventricle to quiver. A heart block is an interruption to the passage of impulses, and sick sinus syndrome is Brady-Tachy syndrome, resulting from degeneration of conductive tissues. Here you can see a normal rhythm. Here is atrial fibrillation, also known as AFib, where the atrium are quivering. Here is ventricular fibrillation, which is the most dangerous or deadly, where the ventricles are quivering. And here is a heart block where there is an interruption in the conduction. Aneurysm is an abnormal dilation of an artery, vein, or heart that is more than 50% the normal. Abnormal stretching or dilation in the wall of the artery, vein, or heart with a diameter at least 50% greater than normal, caused by vessel wall weakening due to trauma, congenital vascular disease, infection, or atherosclerosis, leads to the formation of a permanent sac-like structure. Plaque formation erodes the vessel wall, predisposing it to stretching and sac formation. Stretching of the media produces a weak and thin layer of necrotic muscle or fibrous tissue that bulges with each systole. Over time, the aneurysm becomes more fibrotic, but continues to bulge with each heartbeat. Thoracic aortic aneurysms can result in a tear in the intima due to elevated blood pressure, leading to rapid disruption and rupture of the aortic wall. Aneurysms may be asymptomatic. Manifestations depends on the size, position, and rate of growth. Persistent but vague substernal, back, neck, or jaw pain may occur as the aneurysm enlarges and impinges adjacent structures. Understanding these aspects of aneurysms is crucial for their diagnosis and management, especially considering their potential for serious complications such as a rupture or hemorrhage. Peripheral vascular disease encompasses pathologic conditions of blood vessels supplying the extremities and major abdominal organs, most often apparent in the intestines and kidneys, organized based on underlying pathological findings. Differentiation from peripheral artery disease. Peripheral artery disease refers specifically to diseases of arterial blood vessels. Peripheral vascular disease includes disorders of both arterial and venous blood vessels. Typically affects the legs more often than the arms. Upper extremity involvement is not uncommon. Understanding the distinction between peripheral vascular disease and peripheral artery disease is important for accurate diagnosis and appropriate management of vascular diseases affecting the extremities and major abdominal organs. The inflammatory response is usually accompanied by thrombus formation and vasospasm, which leads to occlusion. Vasculitis is inflammation of arteries and veins. Buerger's is vasculitis affecting the peripheral blood vessels, veins, and arteries. Kawasaki disease is systemic vasculitis. Leads to end-stage organ damage. Vasculitis etiology, immunologic in nature, often associated with inflammation. Inflammation of blood vessels leads to narrowing or occlusion of the vessel lumen, formation of aneurysms. Peripheral neuropathy, paresthesia, muscle weakness, and atrophy are some of the clinical manifestations. The diagnosis is made based on clinical manifestations. Histological examination may be required for confirmation. Management is through pharmacological interventions, therapy targeting inflammation, lifestyle changes to manage symptoms and prevent exacerbation. Arterial occlusive disease. Arterial occlusive diseases involve the narrowing or blockage of blood vessels, often leading to disability. The primary cause typically is atherosclerosis. Other contributing factors include trauma. Physical injury to the blood vessels can cause occlusion, thrombus or embolus. The formation of blood clots or dislodged particles can block arteries. Vasculitis, inflammation of blood vessels, can lead to narrowing or occlusion. Vasomotor disorders, conditions like Raynaud's disease or phenomenon and complex regional pain syndrome can affect blood vessel function. Arterial punctures, invasive procedures or injuries may lead to arterial inclusion. Chronic mechanical irritation, compression of the subclavian artery by structures like cervical ribs can cause arterial occlusion. Etiology, atherosclerosis, trauma, thrombus formation, vasculitis, and chronic mechanical irritation of the subclavian artery. Due to compromised blood flow and tissue oxygenation, they are prone to open wounds. And the two different types are arterial thrombosis and embolism, or peripheral artery disease. Arteriosclerosis obliterans, peripheral artery disease. Symptoms would occur distal to the occlusion. Surgery is indicated when pain persists, even at rest. Etiology is atherosclerosis, primary cause leading to narrowing or blockage of arteries. Cigarette smoking is a major risk factor, exacerbating arterial damage. Diabetes contributes to vascular damage and narrowing. Hypertension accelerates atherosclerosis. Dyslipidemia is high triglycerides. Low HDL cholesterol contribute to plaque formation. Pathogenesis, arterial narrowing due to plaque buildup leads to reduced blood flow. Clinical manifestations include claudication, pain, pallor, weakness, pulselessness. Symptoms manifest when the lumen diameter is decreased by 50% or more. Diagnosis is through vascular tests such as arteriography, ankle brachial index or ABI to assess blood flow to the legs. Management includes lifestyle changes including smoking cessation, dietary modifications, pharmacotherapy with aspirin and statins to reduce clotting and cholesterol levels, skincare to prevent complications such as ulcers. Here are some signs and symptoms of arterial insufficiency: painful walking, intermittent claudication, elevated foot develops increased pallor, venous filling, delayed flowing, foot elevation, redness of distal limb in a dependent position, and death of tissue such as gangrene. Venous diseases include thrombus and emboli, Thrombus is a solid mass of platelets formed within the blood vessel. And emboli is pieces of a thrombus that have broken free and are carried by the bloodstream to other parts of the body. Acute and chronic venous disease. Acute venous disease includes thrombophlebitis. Chronic venous disease includes varicose vein formation and chronic venous insufficiency. Venous thrombus, partial or complete occlusion of a vein by a thrombus with secondary inflammatory reaction in the vein wall. Intravascular collection of platelets, erythrocytes, leukocytes, and fibrin can lead to significant morbidity and mortality. Types of venous thrombus: superficial, affects veins close to the surface of the skin, or deep, which affects deeper veins. Deep vein thrombosis, or DVT, is the third most common cardiovascular disease after acute coronary artery episode and cerebrovascular accidents. Deep vein thrombosis affects lower extremities 90% of the time. Initial symptoms may be dull ache, tight feeling, pain in calf. Progressed DVT symptoms include warm to touch, discoloration, pitting edema, pain in the calf. It is the third most common cardiovascular disease after coronary artery episode, such as MI or cerebrovascular accident, which is a CVA. Occurs in 30 to 60% of all post-surgical patients up to 4 weeks after surgery, with lower extremities being more commonly involved. Etiology includes genetics, lifestyle factors, venous stasis, hypercoagulability, venous wall injury. Pathogenesis is vein wall endothelial trauma leads to exposure to platelets and clotting factors, resulting in thrombus. Clinical manifestations: lower extremity DVT, initially asymptomatic, calf pain and swelling, superficial vein dilation, pitting edema, and positive Homan's test. Pulmonary embolism, pleuritic chest pain and/or discomfort, tachypnea, tachycardia, restlessness, and dyspnea. Diagnosis: Wells Clinical Decision Rule is used for assessing the probability of a DVT. Doppler ultrasonography is a common imaging modality for diagnosing DVT. Management through anticoagulation, bed rest for 24 hours, often recommended initially. Elastic stockings during great toe exercise, used to prevent blood clot pooling in the legs. Prevention: early ambulation is encouraged to prevent venous stasis. Anticoagulants for patients undergoing major surgery can be used prophylactically. Frequent changes in position helps prevent prolonged immobility. Compression stockings aid in improving venous return. And exercise such as ankle pumps hourly promotes blood flow and prevents stasis. Precautions include position limb below horizontal plane, helps prevent pooling of blood. Protect skin, important to prevent pressure ulcers, and avoid thermal agents and massage. They're contraindicated to prevent dislodging of thrombi. Arterial ulcers. Etiology is arterial sclerosis obliterans. Atheroembolism, large or medium vessel atherosclerosis, Raynaud's disease, diabetes mellitus, collagen disease, and vasculitis. The location is anywhere on the leg or dorsum of the foot or toes, primarily at bony prominences such as the lateral malleolus. Clinical manifestations: painful, especially with legs elevated. Pulses poor quality or absent. Intermittent claudication. Rest pain or nocturnal aching of foot or forefoot, which is relieved by dependent dangling position. Trophic changes include integumentary system, such as hair loss, thin, shiny skin, ischemia, pale white skin color. Areas of sluggish blood flow may be red, purple, molting. Hypersensitivity to palpation, and history of minor non-healing trauma. The wound appearance, minimal exudate with dry necrosis, blanched wound base, and peri-wound tissue. Etiology, valvular incompetence, history of DVT, venous insufficiency accompanied by hypertension, peripheral incompetence, varicose veins. Location, medial aspect of distal 1/3 of lower extremity, behind medial malleolus. Clinical manifestations are very painful, pain relief with lower extremity elevation. Venous insufficiency can cause aching pain, more comfortable with legs elevated. Normal arterial pulses, eczema or stasis dermatitis, edema. Venous peri-wound is called hemosiderin staining, which is leakage of hemosiderin is caused by blood that cannot return because of vascular incompetence. The wound appearance is superficial, highly exudative, red wound base, and irregular edges. Vasomotor disorders are affecting the diameter of the blood vessels. Raynaud's disease is spasm of small arteries and arterioles with exposure to cold or strong emotion, causing pallor or cyanosis. Etiology is idiopathic. Pathogenesis and clinical manifestations. There is blood vessel constriction, reduced oxygenation, leading to pale and cold skin. Scientists theorize that Raynaud's phenomenon is associated with a disturbance in the control of vascular reflexes. Diagnosis is based on clinical presentation for at least 2 years. Management involves avoidance of provoking stimuli. Skin care and protection. Intermittent exercises to near max pain progressing to long-term walking program for 30 minutes 3 times a week. Avoid smoking, use protective coverings and keep temperatures at comfortable levels. Daily skin examination and protection. Keep skin clean and well moisturized. Always observe wearing proper footwear. Use heel protectors, sheepskin, or other protective devices when recommended. Do not stay in one position for more than 30 minutes. For Raynaud's, gently warm fingers or toes as soon as possible. Avoid crossing legs, and observe proper care for nails and avoid scratching. Orthostatic hypotension, also known as postural hypotension, is characterized by a decrease of 20 millimeters of mercury or greater in systolic blood pressure, or a drop of 10 millimeters of mercury or more in both systolic and diastolic arterial blood pressure, accompanied by a pulse increase of 15 beats per minute or more upon standing from a supine or sitting position. Etiological factors include normal aging processes, may slow postural reflexes, reducing cardiac output and predisposing older adults to orthostatic hypotension. Changes associated with aging, particularly in individuals with hypertension, further increase susceptibility to orthostatic hypotension. Drug use is a significant cause of orthostatic hypotension in older adults. Pathogenesis includes impaired capacity to increase vascular resistance, leads to increased downward pooling of venous blood. This pooling results in decrease in stroke volume and cardiac output. subsequently leading to a decrease in blood pressure. There are three main modes of presentation in the older adult. One is falls or mobility problems. Two is acute or chronic mental confusion. And three is cardiac symptoms. Clinical manifestations include dizziness, blurred vision, syncope, falls, mobility problems, acute or chronic mental confusion, and cardiac symptoms. Management includes correction of underlying cause, in managing and checking blood pressure for patients with orthostatic hypotension would be to repeat blood pressures in supine, sitting, and standing position. Repeat the blood pressure after 1 and 3 minutes after transitioning to a seated or standing position. Habituation to upright is the goal. Must be identified immediately and carefully monitor patient. Monitor signs for angina, and monitoring vital signs as well as oxygen saturation and heart rate. PTA implications. Be mindful of medications patients are taking. Be cautious with interventions that cause vasodilation. Use heat modalities, whirlpool for example, with caution. Engage in moderate to vigorous exercise of large muscle groups. Implement cool-down periods to control abrupt decrease in venous return. Focus on aerobic conditioning. Habituate to upright technique. Instruct patients to rise slowly after long periods of recumbence. Physicians may order use of abdominal binders and stockings. If experiencing symptoms, patients should assume supine position with lower extremities elevated, however, is contraindicated for CHF patients, or cross lower extremities.